Good afternoon and welcome everyone to the National Association of Counties briefing on Medicaid and the role of counties in local health systems. Thank you so much for coming to learn a little bit about how counties deliver health services at the local level. We are really grateful that you took time out of your busy schedules to join us. My name is Mary Ann Borgeson and I am a county commissioner in Douglas County, Nebraska. Douglas County is our state's largest county with a population of over 500,000, and our county seat is the city of Omaha. As a commissioner, I am active in the National Association of Counties, or NACo. NACo represents all 3,069 counties, parishes, and boroughs here in Washington, D.C. It is my privilege to serve as the chair of the NACo's Health Steering Committee, and so I am pleased to moderate our session today. We are here to have a conversation with you as federal policymakers about how federal policies matter to county government and how county government matters to America. Counties and their residents feel the effects of countless decisions made in Washington, so we are here to work with you, our federal partners, as your actions profoundly impact everyday Americans on the ground where they live and where they work. This is particularly true in the area of public health and health care. The decision Congress makes on how to regulate and fund health services, including public health, behavioral health, and long-term care and hospital services, will profoundly affect our work in county government. Therefore, these decisions will affect your constituents, and it will affect their access to health care and their local tax burden. Let's face it, federal health care and entitlements are complicated. But if you take a step back and look at it from the county's perspective, of the three large federal entitlement programs, Social Security, Medicare, and Medicaid, the first two, Social Security and Medicare, are 100% federal, while Medicaid is a federal, state, and local partnership. The Medicaid program is designed to be a financial partnership between the federal government and the states. Counties are creatures of the states, that is, political subdivisions. States delegate different responsibilities to their counties. Even within states, different counties may be given different powers and obligations. Many states use counties to administer, finance, and deliver Medicaid services on behalf of their citizens. Some states delegate part of the administration of the Medicaid program, like enrollment and eligibility determinations, to counties. And since states often require some of this and require some of the counties to deliver health care services, they may call on those counties to help finance the Medicaid program. One mechanism states use is a transfer of county funds to the states. The state then uses these funds as part of the required state share or match that is called an intergovernmental transfer or an IGT, and is simply how some states choose to contribute their share of the Medicaid program through one of its subdivisions. This afternoon's panel on county health professionals will introduce you to how counties provide the basic building blocks for healthy communities and provide real-world local examples of how federal policies and programs like Medicaid and IGTs play out at the county level. Dr. Bob England will explain how across the country over 1,500 county and county-supported public health departments work with the state and federal agencies to protect the whole population in our local communities, promoting health and wellness and preventing injury and disease. Next is Dr. Ed Mahalik, and he will describe how counties serve people with complex mental health conditions and developmental disabilities. Donald Haney will outline how the 692 county-supported long-term care facilities are able to provide quality care to people who need most intensive levels of support. And finally, Dr. John Shea Shannon will walk you through an example of how the 976 county hospitals across the country provide for low-income and uninsured populations, as well as community services that private hospitals either cannot or choose not to provide. Together, the presentations will illustrate how all these health services are delivered to real people on the ground. We hope you will come to a better understanding of how counties functions as our intergovernmental partners to implement and administer federal and state programs, comply with federal and state regulations, and leverage federal and state revenue streams, all to serve our common constituents. Please note that our distinguished panelists and their biographies are in your packets, and please save any questions for our question and answer session at the end. So let's get started. Dr. England?
All right. Thank you. All right, we have slides. All right, far out. Get our technical stuff going here. I'm Bob England. I'm the director of the Maricopa County Department of Public Health. That's Metro Phoenix. At 4 million people, we're the third largest local public health jurisdiction in the United States behind New York City and LA County. I want to thank NACo very much for inviting me to be here today. I'm on the executive committee and board of directors of NACo, the National Association of County and City Health Officials. NACo works with NACo on lots of different issues very closely. Vicki Bass from NACo's office is here with us. Stand up or wave or something, please, Vicki. So she's a great source of additional information if anybody has more questions about the organization. All right. I'm here to talk about what local health departments do from the perspective of my own and how you should why you should care, rather, about how well we do that. First of all, to steal a phrase from these halls, all public health is local. Okay, we have a federalized system, right? So the CDC, for example, and other federal agencies offer expertise and guidance, but most of the public health authority, nearly all of it actually, is retained by the states, and most of the real work that gets done at the local level. Public health is not health care. It's all those things we do for each other as a society that makes it possible for us to live a healthy life. Think of it like the economic infrastructure. All those highways and communication systems and economic policies don't guarantee any of us financial success. But without it, none of us could be financially successful. You could own a shipping company with the shiniest trucks around, right? But if you didn't have public roads, you'd be out of business. Similarly, a solid public health system doesn't guarantee health, but it allows people to be healthy if they choose to for themselves. If you're repeatedly, terrific health care doesn't do anything for you if you're repeatedly exposed to infectious diseases because of an inadequate sanitation or wastewater system, or you're exposed to outbreaks that aren't cut off, or you're exposed to environmental hazards or unsafe conditions. A top-notch healthcare system under those situations wouldn't save you any money, and a lot of people would still unnecessarily suffer and die. You're about to hear from several others about how counties are involved in aspects of health care, but none of that works efficiently or effectively if you don't have adequate provision of core public health services, and that provision is mostly a local responsibility. We provide services that benefit the entire population, not just members of a particular health plan, not even those whom we may actually touch. When we intervene to stop an outbreak, you're protected because you were never exposed. If a sanitarian inspects a restaurant and fixes a problem, you're protected even though you may not eat there until weeks down the line. On and on and on. So we assure safe environments and protect against health hazards, but we also largely work through other community partners to create healthy policies in schools, workplaces, healthcare institutions, and elsewhere, and to leverage the resources of the entire public health system. This is the only slide you have to memorize, by the way. There'll be a quiz afterwards. There are lots of different entities that impact our health, and we have to work through and with all of them. We also provide some direct services to people that yield tremendous savings to all of us in prevented health care and other costs down the road. And in many ways, this works pretty well. This is a simple graph of the infectious disease death rate over the last century, over the 20th century. A couple of take-home points. One, ain't it good to be alive now? Okay? Our grandparents, my grandparents' generation anyway, lived at a time when it was just accepted and part of life to lose family members suddenly to some mysterious infectious disease. And historically, we have done this pretty well with truly meager resources. But local health departments now are struggling to maintain their core capacity. NACo's research shows that local health departments overall have lost nearly 50,000 jobs since 2008. That's about 15% of the total public health workforce. That's the equivalent to 30 metro health departments the size of Seattle, King County, losing all of their employees. Some, like my department, had very little to begin with. My state and local funding, the last I was able to check, is about 10% of the average per person funding when you look at other large jurisdictions, exemplifying just how wildly different communities commit themselves to public health services. My local flexible funding with which I can address our most pressing issues, local county funding, is less than $3 per person per year. Okay, think about that for a second. Compare that to the cost of health care that you know we all pay, and realize that how much that cost of health care is going to be largely depends on how well I spend those $3. That means, like many local health departments, I am way dependent on federal funding. My local health department is 70% federal funds, largely passed through from the feds to the state health department and then down to us. Many of our activities, like emergency preparedness, for example, are 100% federally funded. There's not one dime of state or local money in that. So we wouldn't be able to do that at all without federal money. Why should you care? Okay, that's all the way out in Phoenix. Because stuff can go wrong that may affect you. We recently spent a year and a half preparing our county's public health and medical system for the Super Bowl that we just had. We established truly extensive surveillance. I was really proud of it, from electronic to field work, to make sure that we could know if anything was awry, and so that our public safety partners would believe us if we said everything was still looking good. We didn't just watch emergency room visits for patterns. We knew what complaints were showing up at the first aid stations at events because we had people there watching. We knew what was going on with ambulance runs, lab reports. We even knew whether aspirin was flying off the shelf at hotel gift shops. Okay, we knew what the veterinarians in town were seeing in terms of patterns of animal illness and so forth. It was really intense. We got really creative with it, but we were still crazy busy. And now, in the midst of that, try dropping a measles outbreak, okay? That required us to track several hundred contacts to known cases and to investigate hundreds of other suspects. We had to drop a lot of our routine disease control work and let some things go simply because I have no bench. I've got no second string. I've only got so many people who are trained and can do this kind of work. So if anything else had happened at that time, we couldn't have responded. And yet we've got a lot coming our way, whether diseases like dengue or chikungunya or mosquito-borne diseases get a foothold in our area in the Southwest and spread to threaten you, depends on how well my department does its job. Same with other diseases, vaccine-preventable diseases, and antibiotic resistance, and so forth. Whether you're ultimately at risk depends on how each of the local health departments do their job. We're only as strong as our weakest link. Okay, so I'll let people look at that for a second. I've been focusing on communicable diseases, right? But that's not the only reason you should care about how well we do population health at the local level. What's killing us now is chronic disease stuff, right? If we don't intervene in this effectively, how Congress decides to pay for health care isn't going to matter, because I swear none of us are going to be able to afford the tab. And let me show you what I mean. How many of you have seen what I'm going to do here already? A few. Okay, that's good. Only a few. This is really fun. You're going to see a few things in this. You're going to see a series of maps year by year of obesity trends in the United States. This is from the Behavioral Risk Factor Surveillance Survey. It's a big, long telephone interview survey that's conducted everywhere. And there are a lot of questions, but two of them are really simple, okay? How tall are you and how much do you weigh? And from that, you can calculate body mass index. It's not a great tool for an individual measurement because, you know, a bodybuilder will seem obese that way. But for populations, it's really good to track trends across time. Okay, so what you have here in the very light blue is rates of adult obesity that were less than 10% at the time, and the slightly darker blue is from 10 to 14%. The white states there were states that weren't yet participating, so you'll see two things happen as we go through the years. All of the states will fill in eventually because now everybody participates in this, and you'll watch the colors change. So this is 1985, which I'll remind you is only 30 years ago. Okay, 86, 87, 88, 89. Do you think you see anything happening yet? 90. A lot of bodybuilders. Yeah, exactly. Now, whoops, in 91, we have to add a new category for 15 to 19% being obese. 92, 93, 94, 95, 96. Oops, in 97, we have to add another new category for more than 20% obese. And I'll note that by now, nobody's in the low category anymore. 98, 99, 2000. Oops, in 2001, we have to add another new category for more than a quarter of the population being obese. 2002, 2003, 2004. Oops, in 2005, we have to add another new category. 2006, 2007, 2008, 2009. Okay, now there's only one state that's hanging out there in a category that didn't even exist when we started. Hang in there, Colorado, 2010. All right. That's as much as I got, okay? Okay, why should we care about this, okay? Because every freaking chronic disease you can think of is associated with obesity. And it's not all due to body fat, it's just the same risk factors. If you're not moving and you're eating junk, you're setting yourself up for a lot of different chronic diseases. And it's all gonna cost us in the long run. You can look at graphs like this of rates of diabetes climbing like mad. In my own county, we anticipate that continued current increases just at the rate we're going is going to cost us an additional $1 billion per year in healthcare costs within the next 5 years or so, every year, and on and on. So what are we going to do about this? Take a lesson from our past and what we did. How did we do this as a society? How did we have this much success? I'll tell you what most audiences, when I talk to lay audiences, say, oh, healthcare is so much better now. Okay, because the biggest tool healthcare has against infectious disease is antibiotics, right? And that's where they first came in. So it's other stuff. When we started putting plumbing in houses at the start of the century, the rates of aquatic disease deaths plummeted. When we stopped shoving people into tenements and sweatshops, for the most part, the rates of diseases like TB plummeted way before we had treatment for it. And that's all passive stuff. That's, you don't have to teach somebody how to use a toilet, you know? You just provide it. It's things around us, it's environmental things that allowed us to do this kind of work. So that's how we're approaching it in my county and in most counties around the country right now. Policy, systems, and environmental change. That's why whatever funding we do get needs to be as flexible as possible so we can go after that. And let me give you one example of how we did this. Our tobacco program, we stopped doing direct services. I stopped our cessation. I stopped things that weren't making a difference to folks. And we did good old-fashioned community organizing, focused in this case with college students. We got college student groups interested in working. It took 4 or 5 years, but both our community colleges and Arizona State University went tobacco-free campus-wide. And data from other studies shows that that'll cause 1 in 5 smokers to quit. Okay? 1 in 5 smokers quitting equates to almost 10,000 students and $1 billion with a B in saved healthcare costs just for the cohort of students that are on campus right now. That should repeat every time there's new students coming in. That's how well this works. There are other interventions that we know our failure to perform costs us $4 to $20 for every dollar we would have spent it to prevent it, sometimes a lot more. And for some issues, yeah, it seems to just be much worse. Here's my plea. Ultimately, there are many ways to create a deficit, okay? When we know we can prevent unwanted costs down the road by spending a fraction of those costs up front, what we are doing is, in essence, borrowing, okay, against the future. And at horrific interest rates that our kids are going to have to pay. They'd make a loan shark blush. It is crucial that we sustain funding as flexibly as possible to address the public health needs of counties all across the U.S. We depend on this funding to keep our residents healthy and safe, to protect others, and to save us all a fortune in future costs. Thanks again for the opportunity to speak. Remember, all public health is local, and we all have a stake in just how well each of the local health departments do their jobs. Thanks.
Thank you. Very, very interesting. And next, again, we'll hear from Dr. Mahalik, who will describe how counties serve people with complex mental health conditions and developmental disabilities. Thank you.
Good afternoon, everyone.
Good afternoon.
It's my pleasure to be with you. My phone is not up here because I'm checking my emails, but I figure if I don't have something to stop me, we'll be here at 8 o'clock at night, and some of you will fall asleep, and the rest of you will leave, and I'll still be here talking. So I'm going to try to keep myself in check, if you don't mind. My name is Ed Mahalik. I'm the County Administrator for Mental Health and Developmental Disabilities for Reading, Pennsylvania. I'm also serve there as the Executive Director of the Area Agency on Aging. I'm here not only to talk about Berks County today, but I'm here to talk about all counties in Pennsylvania and Pennsylvania's history with the Health Choices Program, which is the mandatory managed care program for Medicaid recipients. I'm going to say this in the beginning, and I'll finish at the end with my comments, that we are not simply in Pennsylvania County just additional stakeholders in the system. I would like to maintain and make a case for our being intergovernmental partners with both the state and federal government in following up with what Dr. England referred to as all health care is local. I would maintain that all behavioral health care for mental health, intellectual disabilities, and substance abuse programs starts at home in Pennsylvania and in our counties throughout Pennsylvania and in many, many states, if not all the states. We know the people we serve the best. We know our providers the best. We're able to integrate our services into other natural supports that people would prefer to use rather than rely on government all the time to provide those services. And I also would maintain that we know when there's fraud and where to look for it and where to refer those cases of fraud to the proper authorities for investigation and limit the amount of health care fraud that occurs, thereby saving more money, because we all know that this is a time of great difficulty for our country, for our state governments, and for our county governments in trying to provide and make ends meet for services and not raise taxes and burden our economies more. In Pennsylvania, there are 2.25 million Medicaid recipients. By the way, I do not have handouts, but I do not have a PowerPoint, but everything that I'm saying for the most part is available in handouts and graphs in the back of the room, so you can take it with you and read it. So that way, at least for me, I don't like to write notes. I like to be able to listen to people, so I have the handouts for you. In Pennsylvania, we have 67 counties. The majority of them are rural counties, other than the city of Pittsburgh and Philadelphia and some of our larger southeastern counties. We operate our mental health, intellectual disability, and substance abuse systems within 48 county joinders, meaning some counties join together to provide regional cooperation in a manner that makes sense to our local elected officials. People like myself report to an elected board of commissioners who I think are the most responsive to their constituents. It is not unusual for anyone, rich or poor, to call one of our county commissioners when they have an issue with one of our services, and for to get a call, as well as my peers throughout Pennsylvania to get a call. And wouldn't you rather want to call one of your neighbors and people you know? And if you've been around as long as I have, I used to have a full head of hair, and I was a lot thinner, Dr. England, so I'm an example of this. I know most of the people. I know most of the people in my community, and I can tell you, I know a lot of them on a first-name basis, and they're not afraid to walk into my office and say, "Hey, Ed, I got a problem with this. I don't like my therapist." And I think that's important when people are able to do that, because ultimately it's that fit that makes the difference and causes people to change their lives. As I mentioned, a third of our population lives in rural or small cities. There's a few urban pockets. Our Medicaid managed care system was started in 1997 in Berks County. It started in 2001. Our Health Choices budget in Pennsylvania is $3.05 million. That represents 73% of the county, of all tax dollars that come into Pennsylvania to provide health care. We're able to coordinate with that other percentage of other funds, whether it be people fall in and out of Medicaid funding. They don't have to change their therapist. They don't have to change their providers. They get to stay where they are because we manage that other 27%. And I think that's important. You shouldn't have to change your health care provider, and you don't in Berks County or any other Pennsylvania county. Another reason why I think management of the local Medicaid dollars in Pennsylvania's model works. In Berks County, there's over 83,314 people enrolled. Actually, I'm sorry, $83,314,000 for local Medicaid. Our eligibles in Berks County alone are 65,000 people. And again, as I mentioned, we started in 2001 with our local provision of Medicaid monies and management of that. The main goals of Health Choices are to improve access to health care services for Medicaid recipients. We have very strict standards as to how far from your home that you have to be able to go to get services. We have very strict standards of how long you have to wait for services. We improve the quality of health care through continuous quality improvement and constant provider audits. We also have stabilized Pennsylvania's Medicaid spending by realizing more than $4 billion in savings over 10 years of operation. We do send money back to the state after meeting everybody's needs, and we do not affect cost containment on the backs of our Medicaid recipients. But we have saved money because we do know our local providers and we do know how to integrate our services. In Berks County alone, we've pumped over $9 million of reinvestment monies into safe, affordable, and decent housing. You can't talk to people about how they're feeling if they don't have safe, decent, and affordable housing. And for those of you that are involved in trying to provide safe, decent, affordable housing to the poor, it is very difficult to find safe housing in urban centers such as the city of Reading without that type of partnership. We have built networks of local landlords all across Pennsylvania. We have partnered with developers. We have developed new services based on the savings received through our local management of health choices, and we still have saved money. One of the main cases that I can make as we go through this presentation is there are certain required services that the Center for Medicaid and Medicare Services requires that states provide to Medicaid recipients. But because we manage that other 27% of state, federal, and county tax dollars, we're able to provide that whole continuum of services such as housing, supported living, peer support services, and other services that aren't included in the menu of Medicaid services. Local government can do that when we're responsible for all the monies. We have reduced our reliance on state institutions. We have formed alliances to try to effectively address the fact that there are more mentally ill people in prisons than in some of our programs. And I think it's a national tragedy that we are at that point. And we are better able to do that with county government by forming regional cooperations, because you may have subpopulations of people who you don't have enough critical mass to have a program, but you can turn to your sister counties next door and say, how about we all band together and do this? And we have done that repeatedly through various programs. What about the county program and Health Choices Fit? We address all populations and services. Sometimes the state government has certain priority populations that we should address. Other times the federal governments have certain populations. We deal with everybody who comes through our door. No one gets turned away. We provide a local base for customer services. We work with state and local law enforcement to investigate issues of fraud. We've had several very high-profile prosecutions of Medicaid fraud where people have gone to jail and money has been returned to the public coffers. We need to be about that. The vast majority of our providers are good, decent providers, but when people want to take advantage of the system and increase their volume through what I would call nefarious means, then I think we are the ones best able to figure that out and to refer it to the appropriate authorities. We have risk-based pool contracting. We have standards that are consistent across providers. Benefit packages are consistent across counties. You don't have one set of benefits in one county and travel 2 miles to the south and the benefits are different. They're all consistent. In terms of the strengths and benefits of success, we do a lot of cross-system problem solving, as I indicated to you, through drug courts, through veterans courts, through dealing with corrections and law enforcement. In Berks County, we have trained hundreds of police officers to respond in different manners to people with mental illness, and we're very, very proud of those partnerships. We have a special liaison that is on call that responds to district justices, to judges, and to law enforcement so that we can come up with treatment plans rather than arresting people and incarcerating them for minor offenses so they don't end up in prison. All of our data is, our decision-making is data-driven. One of our biggest accomplishments now is a physical health, behavioral health integration project around the whole concept of health homes and providing both physical health and behavioral health services together. That way, there was a time in Pennsylvania when people who had mental health and drug and alcohol programs went to different programs and you would lose people in the shuffle. Our coordination and our relationship with the drug and alcohol system through Health Choices has been brought together and joined, and people no longer have to search for all kinds of different appointments. We have also joined with a hospital system that has a full array of physical health services and our behavioral health providers. Several counties in Pennsylvania have launched that. We, again, are best able to do that as part of county government. As I get to the end of my presentation, I hit the high parts and be happy to answer questions later and give some of my colleagues some time. And I'm doing good. I'm really pleased with myself. My wife will tell me that I'm trainable if she was here. I can change my behavior. The best thing that I can tell you again is to reflect on your own personal lives, particularly those of you folks here who are important and drive local and drive state and federal policy decisions. That where do you go when you want your car worked on? Where do you go when you need a doctor? Where do you go when you need just about any local service? You go to people you trust, and I believe in Pennsylvania, people trust their county government, their county commissioners, and I think we provide a strong backbone in terms of an intergovernmental partner to improve the lives of our citizens throughout this nation. Thank you for your time.
Thank you. And now we'll hear from Donald Haney. Again, he will outline how the 692 county-supported long-term care facilities are able to provide quality care to people who need more intensive levels of support.
Hi, and thank you for inviting me to be here today and to talk about long-term care and how we provide those services in our counties. I will tell you that most of the county medical care facilities started out back in the 1800s as poor farms. They moved to infirmaries in the early 1900s and then moved to skilled nursing facilities in the 50s and the 60s. I'll also tell you that the 50s and 60s nursing homes are not what we're doing today. A lot of people, when they think about long-term care and they think about skilled nursing, they think of these big 4-bed wards and medications and restraining people and tying them down, and that's not the services that we provide today. Our facilities are done and our operations are done much more in the 21st century, and we deal with things with the behavioral responses versus medication issues. Most of our residents seem to think they're in a 5-star all-inclusive resort. We are county medical care facilities in the state of Michigan are also leading the state in culture change, and by that we mean talking about the resident and looking at person-centered care versus the medical model. For example, there's a federal regulation that you cannot go more than 14 hours without feeding a resident. So in the 50s and 60s, you woke every resident up at 7 o'clock and you fed them breakfast, whether they wanted to get up or not. And if they work second shift their entire life and like to sleep until 10, too bad, you're getting up at 7 o'clock. And if you worked on a farm and you got up every morning at 5 and wanted to eat your breakfast at 5 a.m., too bad, you're going to wait till 7 because that's when we feed everybody. In the Eden culture and the person-centered planning, we allow our residents to sleep in, and we document and we chart, we monitor their weight, and we do it through other measures, but we allow the resident to decide when they want to get up and when they want to have breakfast, because that's we're looking at the whole person, not just their medical issues. So in the old days, the medical model was you treat the medical condition and we don't worry about the rest. Today, we worry about everything else, the spiritual, the social, their mental health, and then we worry about making sure that the medical stuff happens in the background. Oops. Should have set that timer a little longer. So as a county medical care facilities, we also incur high costs. In the state of Michigan, our costs are cost-based reimbursed. So the costs that I am getting reimbursed today in 2015 are actually based on my 2013 filed cost report. So they're 2 years old, and there's no inflationary factor. So I'm getting reimbursed for my actual costs in 2013 with 2015, which means I'm not staying current with my dollars. I'm not staying on top of things. In addition, not all of our costs are even allowable. As Dr. England shared with us earlier, we've seen a rise in obesity throughout the United States. In Michigan, the cost of bariatric equipment, big hospital beds, big Hoyer lifts and scales to move folks around, bariatric versions of those are not a non-covered cost because our cost-based reimbursement system is 30 years old, back at the start of that graph when there were less than 10% of the folks that were considered obese. Now in Michigan, over 25% of us are considered obese. We have a lot more obese residents, yet those are non-allowable costs under the cost reimbursement system. We also have some higher costs because a lot of our facilities are very rural in nature. They may be the only facility within a 50-mile radius, for example. And the costs come in play when you have to transfer a resident to and from a dialysis center 3 or 4 times a week. And it's an hour away or 2 hours away, and you have to send the bus driver and a CNA or a nursing assistant with them. So we have some inherent operational cost issues that are a little larger than those that might be in a larger city. So how do we address those costs? Well, we have the MOE, the Maintenance of Effort Program, which is where the county government, either through the county commissioner's allocation from their general fund or from a millage passed by the citizens, those dollars are paid into the state, and then that's matched with the federal government, and those dollars are returned back to us in the form of a little bit higher reimbursement than our peers in the state. We also have a certified public expenditure program, works very similar in that if our county commissioners or our citizens pass a millage to build a new building or to do renovations of the facility, then those dollars can be matched by the federal government and sent back to us, so we can provide those services. And those additional building things have also very clinical and social benefits. When we went from those 4-bed wards to private rooms, we immediately saw a decrease in behavioral issues within our facility. And I think every one of us here have been on that family vacation where we're in the car for a week or we're in the tent or the hotel room, and after a couple of days, it's like, okay, guys, you just let us be, right? Well, imagine living like that 24/7, 365 days a year in 4-bed wards. So when we spread out our residents and gave them their own private space to go to, it made a huge difference in the quality of their life. Most importantly, when they got up at 3 o'clock in the morning because of their medications routine, they were able to turn the TV on and watch it without waking up anybody else because they had a room to themselves. So it has a huge benefit. Also this year, we had a huge flu epidemic in our building with all our private rooms and with some of the proactive actions of our nursing team. Even though 50% of our staff members came down with either some kind of upper respiratory infection and a couple with confirmed influenza cases, 0 of our residents ended up with any influenza cases. Again, private rooms, you're not spreading disease, you can control it a little better. We did have a handful of them that had symptoms, but we got them on Tamiflu right away, and again, our nursing team just did a great job. So that those county medical care facilities that are able to go to those private rooms because they have the resources through the CPE program or the MOE program are able to improve the quality of the care, which actually reduces costs in the long run. So those are some of the great things about long-term care, and thank you again for letting me talk today.
Thank you. And finally, we'll hear from Dr. John J. Shannon, and he will walk us through an example of how the 976 county hospitals across our country provide for low-income and uninsured populations, as well as community services that private hospitals either cannot or choose not to provide.
Thank you. I can do it. That'd be great. Thank you, and it's a pleasure to be here. Speaking with you all and breaking your computer. I want to particularly thank the conveners in NACo, and I want to also give a shout out to a couple of my county commissioners, Joan Murphy, and Greg Goslin, who showed up. It's always good to get the names of your commissioners wrong on stage. I find it helps at funding time. So I'm going to tell you about just one of our, out of those many county hospitals, I'm going to tell you about one humble little system, and that's the Cook County system. So we're actually a very large system. We became an independent health system in 2008, even though the Cook County Health and Hospital System has existed in one way, shape, or form since the early 1830s. We became a system with an independent health system board in 2008, thanks to our commissioners creating the health system board. We are composed of the Stroger Hospital, the former Cook County Hospital. This was named after our former NACo president and our former county board president, John Stroger. We have a smaller hospital on the south side of Chicago, Provident Hospital. And then we have a variety of ambulatory services. Our ambulatory services started out in the late 1980s as an independent movement by kind of a splinter branch, if you will, within the county system, who said, all those guys are ever thinking about is the hospital, and we have to be thinking in the future about ambulatory care. And so the ambulatory health network is 16 community-based clinics. I'd remind you that the county of Cook, which has a little over 5 million people, is a huge county. It's about 950 square miles. And so even these clinics don't penetrate the community's needs, and that's why we developed our health plan, which I'll tell you about in a minute. We developed and opened in the mid-90s the Core Center. This is a large center that was devised as kind of a public-private partnership, also with an academic partner, Rush Medical College, to take care of people with HIV, and it's the largest single-site caregiver for people with HIV in the Midwest. We provide services at the Cook County Jail and the temporary juvenile detention center in Cook County, which together have approximately 10,000 detainees on any given day. And then we run the suburban Cook County Health Department. The city of Chicago, which has about half the inhabitants of the county of Cook, has its own health department. Cook County Health and Hospital System runs the suburban Cook County Department of Public Health. More recently, we developed a Medicaid managed care plan, and I'm going to go into a little bit of detail about that in a minute. And we're a significant site for training and research. We have approximately 400 employed residents, but on any given day, we have as many as 500 or 600 residents training across our sites, as well as medical students, pharmacy students, and the like. Now, we're big. This budget, which is our FY15 budget, is roughly twice the budget it was 7 or 8 years ago, and that's simply because of the inclusion in that budget of our Medicaid managed care plan called County Care. But a $1.5 billion budget, about 6,700 budgeted positions, as you can see, including a very large number of doctors. This is just the medical staff physicians. This does not count the physicians in training, who I mentioned, are another 400. And then a very large quotient of nurses. Importantly, with the advent of the Affordable Care Act and the expansion of Medicaid in particular in the Affordable Care Act, we've been able to substantially reduce the amount of reliance on local Cook County taxpayer support, such that today it represents less than 15% of our operating revenues. But it's important to note, as others have earlier today, it's important to note that even with that, a very significant amount of the service that we provide is service that cannot be billed. And every year we provide a very significant amount of service, not only that's unbillable, like those services provided by public health and those services that we provide at the Cook County Jail, but we also have, and we will continue to have for the foreseeable future, a very significant proportion of residents of our county who have no ability to pay. This is the historical mission of the Cook County Health and Hospital System, and even today the estimates are that we have something on the order of 300,000 residents of the county of Cook who aren't able to qualify for health insurance of any type, even under the ACA. So this is that big budget, and again, what you see is, you know, if you were playing cards, this is called putting your chips, all of your chips on one end of the table. The huge amount of that pie is per member, per month revenue that we get under the Affordable Care Act for coverage of patients in Medicaid under our managed Medicaid. In 2011, the state of Illinois decided that half of its Medicaid enrollees would need to be in managed Medicaid by 2015. And the way that they operationalized that was to say virtually everyone in the county of Cook, since it represents about half the population of the state, everyone in the county of Cook needs to be in managed Medicaid. So that's been proceeding apace. But you can see that this huge part of the pie is our per member per month managed Medicaid revenue, and shrinking and increasingly shrinking in the years to come is fee-for-service Medicaid that you see at the top right, representing about 44 million. So this continues to go away as varied populations, the traditional Medicaid populations, on the anniversaries typically of their enrollment in Medicaid, are being told, now you need to get into a managed Medicaid plan. But then, not unimportantly, we're also supported by other vehicles, such as disproportionate share funding and funding that came to us through the Budget Improvement and Protection Act of 2000. These are things that are under assault, not only in Illinois and in the county of Cook, but in some of the other states, as people here in Washington start to look carefully at expenditure of Medicaid dollars. But as I'll tell you, with the managed Medicaid program, the big difference with that is that these are dollars that won't go away. And as the previous speakers have alluded to, if we ignore these expenses, we're just going to see them in much more expensive venues, like the emergency department. So we think that this is the right way to go. Now again, our humble system is very, very busy. Every year we do approximately 1 million ambulatory registrations. That includes evaluation and management, so-called doctor visits, if you will, along with laboratory visits and radiology visits. Every year we fill more than 1.9 million prescriptions out of our health system. These are gigantic numbers. And so We've got actually a benefit in numbers, though, and the benefit of scale that we're able to see is with costs. And what we've been able to do is with our Medicaid managed care plan, the degree to which we can provide that care within the chassis of the Cook County Health and Hospital System, which has significant, if you will, station costs, is very important. And as Chair Borgeson pointed out, one of the things that large urban counties provide that simply can't be replaced by other health systems in the areas typically would be things like our Level 1 Trauma Center, our Burn Center, our HIV care. We're the largest provider of cancer care in the region. And that's not something that the other places couldn't pick up, but we've got special expertise in these areas. We're taking care of people who are typically presenting at a later stage, oftentimes people from different countries that they're residents now in Cook County, but they come from a different culture, they speak a different language. And we've got 24/7 interpreter services and the like. So that cultural competence that a large urban health center is able to bring would be very difficult to supplant if it went away. I do want to talk for just a minute in closing about county care, because this has been a critically important development for our health system. So previous to the Affordable Care Act, we were giving, if you will, about $500 million a year of uncompensated care. That's either bad debt or people who had no insurance whatsoever. $500 million a year. In October of 2012, under a federal waiver with CMS, we were able to get a one-year head start on the Medicaid expansion in Illinois. So we were the only organization in the state of Illinois that was allowed to early enroll adults with Medicaid eligibility in 2014. We were able to start that in October and November of 2012. What that allowed us to do was to build a network of providers. That network of providers includes every federally qualified health center in the county of Cook. It includes virtually all the hospitals, including all the academic health centers. So they are all partners of ours. They are contractors within our network, if you will. A member who gets assigned to county care, our Medicaid plan, picks one of those 138 primary care franchises as a medical home. And that medical home is then able to give chronic care and ongoing care rather than those individuals showing up either at our hospital or any of these other participating hospitals as what would have historically been an uninsured, so-called self-pay patient. So this has been a giant boost to the individual's health. I can tell you a lot of stories about individuals who talk about how their lives have been turned around by this because they no longer have to go every month to an emergency room to get their diabetes or high blood pressure or asthma medications filled. And now, just like most of us in the room, I think, they can go and they can get a prescription filled for 90 days. They can see a primary care physician in the office who can immunize them against common illnesses. And the improvements of health, not to mention the improvements in the dignity of these citizens, are critical. But importantly also, this has given our health system financial oxygen. Last year, it brought in more than $200 million of revenue to the Cook County Health and Hospital System. And again, what that has meant is that between 2008 and 2015, we were able to take the local taxpayer allocation to support our health system from $480 million down to $164 million. So this is a substantial improvement, something that we think is critically important to protect here in Washington, the expansion of Medicaid. These are needs that are out there. These people have very serious health problems, incredible amounts of behavioral health problems, and we now think that we're able to do this in a proactive way and help coordinate their care in a way that should, in fact, bend the cost curve. So we're very, very excited about that. The last point that I would just make is that we, like many other large urban county health systems, are trying to take the opportunity to align all the tools that we have. So we've got 4 major tools that I've told you about today. One is our health system, our hospital and our clinics. The second is our suburban public health department. The third is our jail health services, because everyone who's here in a public health department knows what a nexus of public health a county jail can be. And the fourth and the most important recent development is the development of this Medicaid managed care plan. It's my job and my leadership's job, along with the support of our county commissioners, to align those to erase the very significant health disparities that we see in the county of Cook. So thank you for your time, and I look forward to any questions.
We do have time for a couple of questions. Commissioner Rogers?
My name is Chris Rogers. I'm from Douglas County, Nebraska, and Dr. Shannon, can you elaborate on this network you created with the FQHCs and how that came to be and plays out now?
Yes, so is that on now? Okay. So briefly, when we did our waiver with the feds, which I forgot to mention, that sunsetted in July of 14, and we became a Medicaid managed care plan that's managed by the Illinois Department of Health Care and Family Services. But when we did our waiver originally in 2012 with the feds, what they required to us is geographic access, that it be county-wide, and that essential health benefits be covered. The only way practically that we could do that, because historically as a health system, our centers have been largely on the west and the south side of Chicago, and they weren't near to being broadly dispersed enough to cover the entirety of the county. So this was a practical way to do it, and for the same reason we reached out to those hospitals and those academic health centers, so we've got a full portfolio of services. Each of those network providers we have a contract with. We typically pay them Medicaid rates on a fee-for-service, whereas we are getting a per member per month rate, if that makes sense.
Are you able to access or partner with them with 340B on any of that you do because of the rate that FQHCs get?
Yes. So there are tight rules around that, and I have to admit I'm not the content expert in our organization around the 340B pricing, but we can fill, and typically what we're trying to do increasingly as a cost-saving measure is to use refill of medications as a 340B opportunity. And we've got a very large, very sophisticated robotic mail order system. And so we're able to get for our members, if they send the prescription to us, and we can't force them to do that, but if the members are happy with that service, we can send them 90-day supplies that we can purchase under 340B.
Thank you. Any other questions? Up here in front.
Thank you. Joan Murphy from Cook County.
It's
Murphy.
not Joan Gorman?
No, it's not. But Mr. Haney, I had a question for you. With all the services that you provide, is that a full-fledged hospital? Is it a home, nursing home? Is it an assisted living? I mean, what is it that you do, and how is it paid for?
We have, we're a skilled nursing facility, and we are 161 beds. Okay. We average 94% occupancy, so we have around 151 residents in our building at any one given time. And we really have three distinct lines of business. We have the long-term care folks that just need support with their daily living skills. We have a rehab center where we take folks in that had either a cardiac event, stroke, hip replacement, knee replacement. We rehab them when they go home. And then we have a dementia care line where we have a building that's secured and locked down for residents with dementia. I will tell you that 80% of our residents do have dementia. 70 to 80% have a dementia diagnosis. 70 to 80% are ambulatory, non-ambulatory on their own. They need assistance. And 80% of our residents are Medicaid. So the percentage of Medicaid residents in a county medical care facility building is substantially higher than it is in other buildings. The facility I came from prior to working at Thornapple Manor, we tried to keep our Medicaid population around 25%. And every facility has its own goal that they're shooting for, their payer mix. But that kind of gives you an idea of the difference between a county medical care facility. We're the safety net in the county. So we have a much higher percentage of Medicaid residents in our building.
Okay, thank you.
Any other questions? We are at the 3 o'clock hour. Oh, I'm sorry.
I have one.
I didn't see.
Nick Mashon from San Diego. I was curious if the panel can speak to the Institutes for Mental Disease and any impacts that you're having in your communities.
I will tell you that we're seeing a larger percentage of our residents, not just with dementia, but also with psych issues. And so I actually just increased an FTE in our social work department because we have to deal with those behavioral issues in some form or fashion unless we can get their condition under control with medication. But even when you do that, they have the right to refuse medication, so when they stop taking them, then we have behavioral issues again that we have to deal with. So it's becoming an increasing challenge in our segment of business. So.
All right. We are at the 3 o'clock hour. I will say, last night I did a lot of reflecting on what all the activities have been in the conference around health this legislative conference, and I am really excited and thrilled about all of the neat things that are happening, and how apropos it is to end our kind of conference with our health stuff here on the Hill, extending our arms to our congression to say we're here to help, we're here to be partners in all of aspects that we're responsible for. So thank you all for your time today, and we look forward to continuing to work with you.